We've all known her as the director of the Division of Gynecologic Oncology here at UW for many years, and also the surgeon-in-chief of the UW Medical Center.
Mm-hmm.
Great. So thank you so much, Dr. Goff. We're really interested in hearing what you have to say.
Great. Great. Well, thank you so much for having me. And I just want to say a big thank you also to Dr. Eschenbach for all the work that he's done in Global WACh and Global Health and getting us here. And I hope that this can be an extended relationship with our department, and that we can do more together. So I view this just as an initial conversation. And I apologize for not really having a title for my talk, but Allison said to me, the things we want you to talk about are your career path, your research, leadership roles in the university, and what do I see are important priorities for women, adolescents, and children in global health. And so I couldn't really think of a topic that sort of encompassed all those things. So I said, well, I'm just going to leave it blank. So I do apologize for not having a title for this talk. First thing, I think it's always important just to share with you my financial disclosures. I am a section editor for GYN Oncology for Up to Date and deputy editor of the journal Gynecologic Oncology. I receive stipends for both of these things. And then finally, my husband is employed by Lilly Oncology as a medical liaison, but I will not be discussing any of these issues in my talk today. So when I think about my career path, I think about this game here, Chutes and Ladders, which I loved to play as a child. But I have to say, in my path to becoming chair, I've probably fallen down more chutes than I've actually climbed up ladders, and I'm going to share with you some of those things that have happened to me along the way. And when I think about success and failure, one of my favorite quotes comes from Winston Churchill, where he said, "Success consists of going from failure to failure without loss of enthusiasm." And when I think about academic medicine, I think this couldn't be more true. When we think about, how many grants I have written that didn't get funded, how many papers I've had rejected, how many times I've given a lecture and people have fallen asleep, and I'm like, oh my God, what's wrong with me? Or in our daily patient care, as a cancer surgeon, I have a lot of bad things happen in my clinical practice, and what's really important is that I not lose, that I remain resilient, and that I don't take these failures personally. And so, as I look when I'm hiring faculty or I'm thinking about researchers, that sense of resiliency is something that's very important to me to seek out, because I think there is so much failure in academic medicine. So just a little bit again about my personal career path. So in 1993, and I know you're doing the math, I was recruited here when I was 16, so just so you know. I was recruited here to become an assistant professor. My chair at the time was Mort Stenshaver, and he recruited me at 60% clinical and 40% research. And I was very fortunate. He gave me lab space, he gave me startup funds, and my goal was to establish a gynecologic oncology tumor bank and to look at research and mechanisms of chemoresistance in ovarian cancer. The problem is that no one in my division was a translational scientist. I had no mentorship assigned to me whatsoever. And while I'm sure there were people in the university that were looking at chemoresistance, I didn't know who those people were. And to be honest with you, I didn't have the time to get to know them, because even though I was told I would have 40% research time, the reality is every time I stepped into my lab, my beeper would go off, I would have to go do an emergency operation, or somebody, was crapping out on their chemotherapy, and I needed to go deal with that. And so while I was able to establish a GYN oncology tumor bank, we've got one of the longest running tumor banks in the United States for GYN cancer specimens, I really was an epic failure when it came to this whole translational piece of research, and something honestly that I still regret to this day, that I wasn't able to be more successful as a translational scientist, because this was something that was very important to me. But what I learned from this experience was one, the importance of a mentor. And that, I think, was one of the primary reasons why I failed at this endeavor. And also having very realistic expectations about what does 60% clinical mean and what does 40% research mean, and having realistic expectations within the division that I worked as. So when I became Division Director of GYN Oncology, one of the things that I really focused on was mentorship, and making sure that mentorship was a cornerstone of what we did in our division. And so when I had fellows and faculty come on, they were always paired with at least one mentor. These were formal mentor and mentee relationships, and with clear expectations of what are the benchmarks that people are going to do. How long is it going to take you to do your preliminary research? How long is it going to take you to do this? When are you going to apply for your K award? How is that going to work? But that it's very prescripted and very much mapped out. And then also clinical and research responsibilities are clearly defined. So when we have somebody who is 80% research, that person only works, one day per week, and we decide what day that's going to be, and then the other days are going to be truly protected time where the other faculty members take the beeper calls, are really allowing this person to do their research. And we found that this has been a very, very successful model for people to gain the skills that they need and also to get funding. So after I had sort of failed at this idea of being a translational researcher, I was kind of like down and depressed about my life and about my skills and everything. And my chair at the time said to me, Barbara, there's this great faculty development conference that's happening. By the way, it's in January and it's in Hawaii, and I'm going to pay for you to go because I think that you would benefit from going to this. So that was kind of a no-brainer. Show up at this faculty development conference. And one of the sessions that they had was, how do people who are busy clinicians do meaningful research? How are you going to get funding? What are you going to do? And this was a very important session that I attended. And one of the things they said is that you should think about doing research in things that you spend a lot of time doing. And that kind of is a no-brainer, right? But I hadn't really thought about that as a busy surgeon. And one of the things that I was spending a lot of time doing at that point in time was teaching surgical skills. And it's something that I'm very passionate about teaching surgery. And so I came back from this conference, and this time, rather than trying to do something alone, I brought together a team of dedicated clinicians who also were very passionate about teaching surgery. I also was smart this time, and I made sure to involve a PhD educator who could really help us, design the studies that we were planning to do. And this turned out to be, a very successful program where we were able to analyze the most effective methods to teach and evaluate surgical skills. This also allowed us to get funding from a lot of national organizations, the American College of Obstetricians and Gynecologists, Association of Professors of Gynecology and Oncology, and then we've gotten a lot of funding from the National Board of Medical Examiners to look at this. And really these studies led to a comprehensive curriculum with both bench and animal simulation for surgical training. And this program that we developed really became a model for many residencies within the United States. And now a lot of the evaluation tools that we developed are actually being used by the American Board of Obstetrics and Gynecology for actual skills assessment. And so this was a very successful program. But again, the lessons that I learned from this really were, identifying ways to incorporate research within a busy clinical schedule, and that not everyone needs to do translational research to be, a successful academic physician. And then again, the importance of collaborating both within and outside the department, and not trying to do everything by oneself. The other thing that, during this time, there were many opportunities that were provided me through active promotion of my department chairs and my division chiefs. And this really allowed me to have sort of critical connections that allowed me to advance into national leadership positions. I've been fortunate to be the chair of the Society or the president of the Society of Gynecologic Oncology, and a lot of other national roles, both within ACOG and the National Board of Medical Examiners. And so what I try to stress with my division chiefs now is that senior faculty really do need to take an active role in promoting junior faculty whenever possible. The other thing that my chair, Dr. Stenshaver, he said to me is that, committees and meetings are just a huge drain on academic productivity, and often women are put into those roles to do that. And so he was very specific about limiting committee participation to only things that serve a strategic interest. And what I do with my junior faculty when I was division director is I told them they had to run everything by me, and if it met a strategic interest, we would do it. If not, then I was the one who said no for them, and if people got mad, they got mad at me. They didn't get mad at the faculty member, but that's a strategy that's been very effective. Now, another area of research that I've been actively involved with is looking at health services research and outcomes-based research, predominantly in ovarian and endometrial cancer. And there is a researcher here named Laura Mae Baldwin. She's in family medicine. She does a lot of research in cancer disparities between urban and rural patients, and uses a lot of the WAMI resources to do her research. But she called me up one day and she said, the CDC is putting out a special interest project to look at outcomes in ovarian cancer because such a large percentage of women in the United States actually get substandard care, particularly when it comes to surgery. And we really view this, CDC is viewing this as a public health crisis in terms of how ovarian cancer is being managed in this country. And so we were able to team up together and team up with the CDC, and we have done a lot of special interest projects with them. We have looked at factors associated with guideline therapy, what are the factors associated with optimal surgical care, how and when are primary care physicians involving GYN oncologists in the care of women with ovarian cancer, because outcomes are so much better when GYN oncologists are involved. We've also looked at appropriate referral for genetic counseling, because this is a very important way of preventing ovarian cancer, as well as appropriate screening for both breast, ovarian, and colorectal cancer. And now we've moved into a lot of cost stuff and sort of identifying that when you do the right thing, you actually save health systems quite a bit of money by doing the right operation the first time and having the right people involved in your care. So the other area that I wanted to talk about, the research that I've done, because I think it may, as I said, I'm not a global health researcher, but this area of research certainly could be applicable within the global health field, and this is looking at ways for screening and early detection of ovarian cancer in a very low cost way. So it's not resource intense. And back in 1999, I had been talking at an ovarian cancer survivor course, and there were probably about 50 women in the audience who had ovarian cancer. And we were just presenting all sorts of the new therapies and all sorts of other things. And there was a question and answer session, and one of the women raised her hand and she said, well, can you as a panel, can you guys elaborate on what are the early symptoms of ovarian cancer? And the panel was like, well, there really are no early symptoms. I mean, all the textbooks say ovarian cancer is a silent killer. People don't have symptoms until really, really advanced stages. So, we don't really have much to answer about this. And literally, this group of women erupted into an angry mob and started screaming like, how dare you doctors perpetuate this myth? We've all compared notes. We all had symptoms. We were blown off. You guys you're just like terrible. And we all were like, oh man, we feel kind of bad about this. And so I was talking with some of the women at the break, and they said to me, Dr. Goff, why doesn't anyone believe us that we had symptoms? And I was like, well, there's no research that has really shown that women have symptoms. It's just not been done. And they said, well, you know, would you be willing to help us do some research? I was like, okay, sure. I mean, I had a patient had left me a couple $1,000s for research, and I wasn't really sure what to do with it. So I was like, sure, why don't we start by doing a survey? And I really thought that would be the end of it, that we would just do a survey. We'd find that women didn't have any symptoms, and then we would be done with it. And then, you know, these women would be happy. But lo and behold, we found something quite different. And I'm going to talk a little bit more about that research. But through this $2,000, sum of money, we then got the survivor community very, very interested in this research, and we did a number of case control studies. This led to NIH funding for screening in low-risk populations, looking at early cancer detection, and also doing some very interesting biomarker studies where we combine symptoms and biomarkers together. And so what I really learned from this experience is that, one, you should be open to alternative research opportunities. I had no intention of studying symptoms. I thought it was kind of a ridiculous thing to study. But of all of the research that I've done, this area, it led to a lead article in JAMA, which I never thought as an OBGYN I would ever have a lead article in, you know, the regular, you know, JAMA publication. Also, it's really taught me the importance of philanthropy and working with the survivorship community. And certainly, it's really nice when you get unrestricted funds, and you can be a lot more creative when you don't have all of the restrictions and things going on. So just to delve a little bit more into this area of research, one of the challenges with screening for ovarian cancer is that even in a state like Washington, where we have a very high incidence, I think we have the second highest incidence in the United States because we've got a lot of Scandinavian blood here, the incidence is 40 per 100,000, which means that there is one cancer per 2,500 women. If you look globally, Africa, China, you know, they probably have incidence rates of only 10 per 100,000. Those rates are increasing, though. In North America and Europe, the incidence is decreasing. But in Africa, because women are living longer and they're not dying of infections, they're not dying in childbirth, the incidence is actually increasing as women get to live longer. But the problem with ovarian cancer screening is that the way we make a diagnosis of ovarian cancer is through a major surgical procedure. So even if you only have a 1% false positive result in your screening, that would result with an incidence of 40 per 100,000 and 25 surgeries per every case of cancer, which is really considered unacceptable. About 10 is sort of the maximum that you want to see when it comes to screening. So there have been two large studies that have looked at multimodality screening for women for ovarian cancer, one in the U.S. and one in the U.K. This is the PLCO, which is the prostate, lung, colorectal, ovarian cancer screening trial, which enrolled about 78,000 women, all of whom were postmenopausal. And women were randomized to annual transvaginal ultrasound and CA-125 versus routine care. And when they did their baseline analysis of the first 28,000 women who were randomized to screening, they found that CA-125 was elevated in about 1.5% of patients. Transvaginal ultrasound actually abnormal in almost 5% of patients. But when you look at the positive predictive value for cancer, it was a 1% for ultrasound and 3.7% for CA-125. So you could tell right here that this was not going to be a positive trial because the positive predictive value needs to be at least 10% in order for this to be, you know, truly an effective screening test. And so lo and behold, when they reported out the mortality statistics, they found that there was no difference in ovarian cancer mortality between screened and usual care patients. And the other thing that was concerning was that of the patients with a false positive screen who underwent surgery, 15% actually suffered a significant complication, which is pretty outstanding. I mean, pretty appalling when you think about it. This study in the UK was an even larger study. There was 200,000 postmenopausal women. 100,000 were randomized to control, 50,000 to annual transvaginal ultrasound, and 50,000 to annual CA-125 analyzed using the risk of ovarian cancer algorithm, which means that you look for small changes within the normal range of CA-125. So normal CA-125 is 35, and what we look for is if somebody had a 10 one year and they went up to 20 the next year, even though that's normal, that's not normal for that patient. And so that's how they use the algorithm, and then they follow that with a transvaginal ultrasound. The actual way that they do the screening, you can see here, this is not something you could use in a global health setting at all, because you can't even do this in the United States in most physicians' offices. This is a very complicated algorithm that requires a lot of repeat visits, and really something that's probably, we'll get to whether it's effective, but I'm not sure that this would be feasible in most physicians' offices. So in 2016, they reported out their final mortality statistics. And just by looking at the number of deaths in the controls, multimodality screening arm, and ultrasound, you can see it's probably not going to make it in terms of big differences. And what they found was that there was a 15% mortality reduction in the multimodality screening group, but that was not statistically significant. And same for the ultrasound group. They did see what's interesting is that there was a higher reduction in mortality after screening had stopped. You typically wouldn't see that, so that was a little bit of an oddity with this study. And then these investigators all had a financial stake in making this product potentially commercially available. And so what they did is they said, well, if we exclude prevalent cases, and it's fine to exclude prevalent cases, we found that there was a statistically significant reduction in death. The problem is what they defined as prevalent cases were any cancers that occurred years 0 through 7, which is of course ridiculous. You can't do that. And so that there are many articles that were written to the Lancet. This was published in the Lancet afterwards, saying, this is completely ridiculous that these authors are being allowed to say this in a publication such as the Lancet. So currently, the U.S. Preventative Service Task Force gives ovarian cancer screening a grade D recommendation, which means that there's fair evidence to recommend its exclusion from a periodic health exam, because the U.S. Preventative Service Task Force feels that more women are harmed by screening than are actually helped with early detection. They do give genetic testing a grade B recommendation, as this is a great way to prevent ovarian cancer, which is really the best thing that we can do for patients. So in the United States right now, the current way that we make a diagnosis of ovarian cancer, and this is endorsed by both ACOG and Society of Gynecologic Oncologists, is that clinicians should have a high index of suspicion in a symptomatic patient, and educating women and practitioners about symptoms and promptly initiating follow-up is currently the best method of diagnosis. And the second bullet really came from the work that our group has done looking at symptoms. So as I said, currently screening isn't recommended in the general population, yet 80% of ovarian cancers occur in women without a family history. And the question that I had after speaking with the survivors was, is there a way to make an earlier diagnosis in these women, and a way that would be low cost? So as I said, after I had been at that meeting, that survivors meeting, we decided to team up together, and our goal was to conduct a large national survey of women with ovarian cancer. We wanted to evaluate the preoperative symptoms which women experience, and again, evaluate potential causes and delay diagnosis, because these women were saying, we're getting blown off, and this is a common theme that the doctors are blowing us off when we come into their office. So we surveyed 1,700 women, and we found that what these women said was absolutely true. 95% of women had symptoms prior to their diagnosis. Abdominal and GI symptoms were the most common. GYN symptoms were the least common. And the other really interesting thing that we found was that 89% of women with early stage disease had the exact same symptoms. And what's important is that for women with early stage disease, they have cure rates of 70 to 90%, compared to the sort of 20% that we see with advanced stage disease. We also asked women, how long did you have symptoms before you went to the doctor? You can see that most patients were being seen within 6 months, but 35% were waiting more than 6 months to see the doctor. And when we analyzed those patients, we found that they were much more likely to have advanced stage disease than people who were coming in quickly to the physician. Now, one of my favorite questions, actually, that one of the survivors on our research team suggested that we ask women was, prior to your diagnosis of ovarian cancer, what did your doctor tell you was wrong with you? Okay, and this was a really interesting question. So 15% were told that irritable bowel was the cause of their symptoms, 13% were told there was nothing wrong with them, 12% were told that it was stress that was causing their symptoms, and 6% were told it was depression that was causing the symptoms that women were having. Interestingly, 30% of patients were actually treated with a prescription medication for another condition before being diagnosed with ovarian cancer. So again, what these women were saying, that they were being blown off and they were being misdiagnosed, was really true. I was really sort of shocked by this information. And so what we concluded from that is that a majority of women with ovarian cancer do have symptoms, a majority of women with early stage do have symptoms, and delays in diagnosis are common, both from a physician-related side and a patient-related side. So after we did this, we decided, well, we didn't have a control group. This was really just a quick, survey that we did. We decided we better do a case control study. And this is a study that was actually published in JAMA. And this is where, again, the survivor community was really instrumental in funding this research. And so our goal was to identify the frequency, severity, and duration of symptoms that are typically associated with ovarian cancer. But we did this in a population of women who were presenting to primary care clinic. It's actually Women's and Internal Medicine Clinic over at Roosevelt. And we compared that to 128 women with masses who ultimately ended up having cancer. But they were surveyed about symptoms prior to surgery before they knew whether they had cancer or not. We're trying to get rid of some of the recall bias, but it's almost impossible to completely get rid of recall bias with something like this. And so what we found was that women with cancer, did have statistically more pelvic pain, abdominal pain, difficulty eating, bloating, increased abdominal size, and urinary urgency. But the odds ratios weren't all that high. And so when we started looking at this data, we're like, we don't know if symptoms are really gonna pan out to being important as a way to make a diagnosis for physicians. But then we looked at the number of episodes each month, and we saw that there were real big differences between cancer and primary care clinics. Women with cancer were typically having their symptom almost every day or every other day, where those in the primary care clinic were typically having their symptoms only a couple times a month. And then when we looked at the duration of symptoms, we saw that women with ovarian cancer were typically having symptoms of more recent onset compared to those in the primary care clinic. So after we did this, we decided to see, is there a way that we can sort of model a symptom index that could be used in a primary care clinic as sort of a screen for women with ovarian cancer. So again, we did another case control study where we took 149 women with ovarian cancer, and a lot of these were early stage patients because we didn't take people who had omental cake and ascites and pleural effusions, because we already know those people have cancer. They already know they have cancer. But we took women who had earlier disease. It was unclear whether they had cancer or not. We had almost 500 controls, and again, we evaluated type, frequency, severity, and duration of symptoms. And what we did is we split the group in half, and we did our statistical modeling where we found what is the index that's going to give us the highest sensitivity, and then we tested it in the second half of our patients. And so the index that gave us the highest sensitivity for detecting cancer included having abdominal or pelvic pain, increased abdominal size or bloating, difficulty eating or feeling full quickly. The symptoms needed to be present for less than a year, and they needed to occur more than 12 days per month. And when we looked at the sensitivity and specificity, sensitivity for detecting cancer, depending on the age, ranged from 66.7 to 86.7%. I will tell you that CA-125 has a sensitivity of about 70%, so we're not doing all that much differently here. For early stage disease, we missed a fair number of early stage disease, late stage disease less so, of course. And then when we went back to our JAMA paper and we said, okay, well, if we had, used the symptom index in our primary care population, what % of patients would be positive? And it was about 2.6%, but only 1.4% of those who were over 50. So that then led us to do our big clinical trial, where we wanted to screen everyone with a symptom index and then offer them CA-125 and transvaginal ultrasound. And when we initially put in our study and we got our pink slips back, or our reviews, basically we were told, this is not an acceptable proposal. You are going to cause cancer worry in patients. You're going to create difficulty in physician offices. This is going to really screw up everything. And this is going to result in high rates of unnecessary surgery with secondary complications. So we were like, well, okay, great. We'll use these as our primary, these will be our primary aims. We're going to see, do we really do this? So we sort of changed our focus a little bit and use those reviews to make our specific aims. And so our goal was to determine the potential harms and patient provider satisfaction with symptom-triggered symptom-triggered screening for ovarian cancer. So what we did is we enrolled women from the primary care clinics at UW-MC, and all the women filled out baseline health information. They did a symptom index on their own, and then women were offered transvaginal ultrasound and CA-125, and then if either of those were abnormal, they were managed according to standard of care. Is what we did. And so in our first 2,000 patients or so, we evaluated provider satisfaction, we evaluated cancer worry, we evaluated patient satisfaction, we evaluated how much time it took patients to fill this out, how much time did people estimated increase the difficulty in the office. And basically what we found is that there are very high levels of provider satisfaction, patient satisfaction. It took patients about 2 minutes to fill out the survey, the symptom index, if even that. They were all able to do it on their own. And there really were no issues in physician offices. In the first 5,000 women we screened, we found actually that our symptom index was positive in a higher rate than we thought it was going to be. So that sort of curtailed our study a little bit, because we were offering a lot more people ultrasounds and transvaginal ultrasounds than we had budgeted. So we weren't able to get to our total target numbers, because we ran out of money. But in the total of 6,000 patients that we treated, we looked to see what were the tests that were done secondary to screening only. We took out anybody who was having tests because of standard of care. And what we found is in this group of patients, there were 8 endometrial biopsies that were performed just because of participating in the study. Actually, 2 of those women ended up having endometrial cancer. There were 3 laparoscopies that were performed, 2 for endometriomas and 1 for a dermoid cyst. 1 hysteroscopy was done for a benign polyp, and then 1 THBSO was done for an atypical leiomyoma. So the false positive rate for laparotomy or laparoscopy was 0.08%, so less than 1% risk of having an unnecessary procedure or laparotomy or laparoscopy due to participation in this study. Because we're in a SEER area, we were able to take all of our patients, and we only allowed people to enroll in the study if they lived within a SEER catchment area. And we were able to look to see how many of these patients developed cancer. These are low numbers. As I said, we're only expecting 1 out of every 2,500 patients to end up, having cancer. So that's why these numbers are low. But we looked at how many cancers were diagnosed within 6 months, because we would expect a symptom index not to become positive until about 6 months prior to surgery. So we had 1 patient that was symptom index positive who was diagnosed with ovarian cancer 31 days later, and she had distant disease by SEER criteria. There was 1 patient who was symptom index negative at the time of the study, and 78 days later she had surgery. She had actually risk-reducing surgery because of a high risk of family history, and she was found to have a small stage 1A fallopian tube cancer. We had 6 other cancers that were diagnosed 281 to 843 days after the symptom index. The mean was 569 days. All of them, as we expect, would be symptom index negative at the time of the study. And of these 6 patients, 3 were actually diagnosed with regional disease, which is an earlier stage disease in the SEER criteria. 3 were diagnosed with distant. And while these are small numbers, all of these women did receive education about symptoms and symptoms that they should be concerned about at participation of the study. So, at least in the paper, they allowed me to keep the statement that, maybe because of education, these women were diagnosed earlier. Whether that's true or not, I don't know, because it's small numbers. There's one other study that suggests that symptoms are really important in ovarian cancer, and this is called the DOVE study, which is published out of Montreal. And this was a study in which women who are 50 and older who had symptoms that had been described through our work in ovarian cancer were enrolled into the study. And basically, they advertised in clinic offices, they put ads in the paper, put ads in the radio, saying, if you've got any of these symptoms, why don't you give us a call? And what they did is they then did a CA-125 and transvaginal ultrasound within 2 weeks of study enrollment. If the CA-125 was intermediate, meaning it was in the high level of normal, they repeated it again in 4 weeks. If the CA-125 was normal, they repeated the CA-125 in 4 months if the patient continued to have symptoms. And then the DOVE patients the outcomes of the DOVE ovarian cancer patients were compared to those in the general clinic population in Montreal. And so they had 1,400 women who enrolled in this study, and what was really interesting is that there were 11 cases of ovarian cancer that was diagnosed in these 1,400 women. So what they found in this group, the prevalence was 1 in 132, which is, almost about a 10 to 15% enrichment of cancer in these symptomatic patients. And when they looked at the stage distribution of these patients, 4 were diagnosed with stage 1 or 2, and those women would have a 70 to 90% chance of cure. 4 were diagnosed with small volume stage 3 disease, and those women have about a 40% chance of cure. And then 3 were diagnosed as advanced stage suboptimal, and these patients have about a 20% chance of cure, maybe 15%. When they looked at the clinic population, they found that, those who had just presented, that actually 56% of those were suboptimal patients, again, with that, 15 to 20% chance of cure. So there did seem to be some stage migration, again, very small numbers, but suggesting that symptoms are important. In addition, there were 11 endometrial cancers that were detected in this study. So of these symptomatic patients, 1 out of every 66 was actually diagnosed with a GYN cancer. So it's a really high prevalence of cancer in these symptomatic women. So, we've done a lot more work, and I want to leave time for discussion, but basically what we can say is that there's no effective screening test currently available for ovarian cancer, and early diagnosis does rely on symptom recognition by patients and practitioners, and I think our work certainly supports that. I was also asked just to talk a little bit about my leadership roles at UW. And as we talked about before, I've been division director of the GYN Oncology Fellowship, GYN Service Chief, medical director of an inpatient GYN Urology and Medical Oncology unit. I've been surgeon-in-chief since 2015. I've also been the medical director, or am still the medical director, of our 8 Southeast Outpatient Oncology and Infusion Center. And then, as we said, since 2017, I've been chair of the department. When I look at running an academic department, I think there's a lot of challenges that we face in running an academic department. I think the first is, our changing healthcare environment is really, I think, stressful for all of us. We have, macro, we have MIPS, we have APMs, we have a whole lot of alphabet soup that we're all trying to deal with and trying to figure out how are we getting paid in this new environment. And I think that changing paying environment, it creates a lot of stress, particularly for chairs and for the hospitals. I think it's always difficult to sort of balance the department's financial success against the clinical research, teaching, and community service missions. Certainly, if there's no margin, there's no mission, but the margin can't be the mission. And so finding that right balance, I think, is stressful. Research funding, as we're all aware, is just, very difficult these days. I had a faculty member who submitted an R21, and she was scored in the 11th percentile. And when we called the program officer, they're like, you're not even on the bubble. Just don't even think about it. And it's just a little disheartening when at 11% you're not even on the bubble. Fortunately, she replied, she got to the 2nd percentile and she's funded, but that's just an incredible amount of stress for us to have to always be, in that really, that higher echelon of area. And so, again, I'm really working to identify philanthropy as a nice way of trying to have unrestricted funds if we can. I think particularly in OBGYN, work-life balance is a big issue. When you look at studies as to what is most likely, who are the people who are most likely to have physician burnout, it's women. It's women who are married to other physicians and women with young children. Okay, so probably a lot of you in this room fall into that category, but about 70% of my faculty fall into that category. And so that's another challenge in terms of working on wellness that I think we have to focus on. And then I think partnering with the institutions and for us, with UWMC and Northwest and Valley in, finding ways to reduce costs of what we do. Physicians play a major role in the costs, particularly of procedures and other things that we do, and then working to improve quality. And so finally, I was asked to talk about, what do I sort of see our global health priorities? I think family planning and contraception really is probably the most important thing that we can do when women can choose when and how they would like to reproduce. It makes for healthier babies, healthier moms, and overall better outcomes in the communities that they live in. And people have seen financial and economic benefits from women having contraception. Prenatal care obviously is also critical in terms of having healthy outcomes for moms and babies. Very important for families and communities that we have strong prenatal care to prevent to prevent the outcomes that we don't want to have happen. As a cancer researcher, HPV vaccination is just near and dear to my heart. I have been a spokesperson for the CDC, going around the country educating pediatricians and family practitioners about HPV vaccination and the fact that, particularly, and I don't know globally, but certainly in the United States, we are just seeing the incidence of HPV-related cancers just continue to rise. And what's very interesting is that in the United States, I think in 2021, it's predicted that more men will die of HPV-related cancer than women will. And I think maybe when that happens, then maybe some of our policies will change about, school-based vaccination and universal vaccination, because I really think that is critical. And when we look at the global burden of cervical cancer, I mean, over 500,000 women get cervical cancer every single year, and 250,000 of those women die every year from what I believe is truly a preventable disease. And I think we have to think about cervical cancer as a preventable disease. And this is way, treating for cervical cancer, radiation surgery, that's really expensive. And when you think about the cost of an HPV vaccine, it doesn't take much to sort of think about the cost-benefit analysis. And my understanding is that in Rwanda, they have almost a 95% HPV vaccination rate, because the health minister has basically issued this plan that everyone will have school-based vaccination. In the United States, in this state we're at about 67%, but we're down around 50% in the United States for HPV vaccination. And for boys, I think it crept from 16% to 20%. And as I said, men are going to be much, they're going to have more HPV-related cancers than women are. So I think that this is just really, an important area. Most of cervical cancers are diagnosed, in Africa. I mean, that's really, and most of the deaths occur in Africa. So I think there's just an amazing opportunity, for global health work. And then I think finally, prevention of abuse of children, women and children. I think that, you know, these are, in many countries, women and children are incredibly vulnerable people. And doing what we can to prevent abuse is also, I think, you know, very important area. So I want to thank you for having me and allowing me to tell you a little bit about myself. As I said, I'm anxious to have this partnership continue and flourish in the future. So hopefully we can have a little bit of a discussion now. Thanks. Are you talking about here in the States, or are you talking about?
I'm talking about Washington State.
Washington State. Yeah, and
I gave a lecture to my daughter's class, ages 10 to 14, because they grouped the classes up in the north of Washington. And the teacher who was there jumped up as soon as I mentioned HPV. No, you can't talk about it, because it's a sexually transmitted disease, I guess. But there is really
What's interesting is hepatitis B is also sexually transmitted or through needles, and you can't go to kindergarten in the state without having a hepatitis B vaccination. And so I think part of it is that there needs to be a lot more education. It's one of the reasons that I participated with the CDC in educating. Yeah. But I think it's a matter of education, and Judy, you may be able to.
Well, actually, hepatitis B is an interesting contrast, because we screwed up with hepatitis B when we initially launched it, because as you may remember, it was launched just for high-risk populations. At that time, it was particularly targeted at men who had sex with men, and we were not able to get the kind of coverage we needed or wanted until we went to universal infant immunization, right?
Mm-hmm.
And so one of the interesting questions that's now come up is whether we could reformulate, particularly as we move back first to 2 doses, and now there's, as I'm sure you know, exploration of the single dose.
Mm-hmm. Mm-hmm.
For HPV.
Mm-hmm.
But if you missed your 2 doses, now they're recommending 3 doses if you don't get the first 2 by age 18.
But the work now is looking at whether we could cover really well with a single dose. The Gates Foundation is looking at that. But the other question is, could we reformulate and actually have this be an infant immunization and then boost just
Before middle school, when you start engaging in risky behavior.
Right.
Yeah.
Just before coital debut. And so, I think the lessons from hepatitis B actually are very pertinent.
Mm-hmm. Mm-hmm.
The whole strategy, we started launching this framed as an STD vaccine.
Which was so wrong. Yeah.
Yeah, but you know why that happened? Because I was at CDC at the time. We took it up in our division because everybody else, the breast and cervical cancer program, was ignoring it.
Mm-hmm.
And you're right. We should have handed it off much more quickly to the National Immunization Program. Now that's finally happened, and the increases that we're seeing, I think, are thanks in part to that. But you're absolutely right that the lessons are really there are a lot of analogies.
Yeah, and hepatitis B, it's a cancer prevention vaccine. I mean, that's really what it's all about. And really, this is even better, because not only does it prevent cancer, but it prevents warts. And if you look in Australia, where they have about an 80 to 82% vaccination rate, warts have completely gone away. They don't treat warts anymore, because no one's getting warts, because HPV 6 and 11 have basically been taken out of the community, which is a really exciting, it's a really exciting thing.
The other thing that we're beginning to talk about is whether we could actually do the cervical cancer elimination
Yeah.
particularly if you think globally.
Yeah.
And so there's some interesting discussion that we should follow up on.
Sounds good.
So since we're on this topic, thank you for this overview. But if you go into the wards in the University of Nairobi, in the GYN wards, there are about 5 to 7 women there with catheters, urinary catheters, who had surgery for cervical cancer. So the cervical cancer treatment there is basically non-existent. And so not only is that a really large problem in Africa, but it is not treated at all within modern methods. So that for those of you who don't know, the cervical cancer goes into the lower part of the genital tract and structures the kidneys, and then the kidneys block up and have urinary catheters. It's a bad disease. It's not treated really.
Yeah, and it's a horrible death. I mean, for a lot of these women, because there's bleeding and it smells and it's, you know, it erodes into the bladder and it erodes into the rectum, and you've got like stuff coming out all over the place, and it's just really, it's really horrific. Yeah, Jenny.
Sort of a comment that when you were talking about a lot of your research more in the surgical education and outcomes when you have gynecologic oncologists, I was just thinking that, you know, one of the global health priorities is also, yes, cervical cancer prevention, but I think also training of providers of advanced surgical skills for treating, you know, cervical cancers, endometrial cancers, ovarian cancers, because as community or as countries become more middle income
Mm-hmm.
or advanced, that we'll see more of those numbers.
We definitely already are. Yeah.
So I was just thinking like the SGO or other, I was wondering if other SGO or other things have like global training.
Yeah, they do. They do. Yeah.
Barbara, that was really an inspiring talk. I think that one thing I really liked, and I think it's good to figure out ways to encourage more, was a bit about how you were so entrepreneurial and thinking about the patient's voice and repurposing money from the ability to start building opportunities with this, and then also taking a critique that, you know, triaged you and then submitting it to actually address this completely different solution. And I think those types of lessons really are going to persist as funding gets lower. I was curious about your ideas about how to keep a little bit of that kind of versatile funding for people who want to pilot ideas that come from.
Well, as I said, if you can get some unrestricted funds from donors, I mean that's really where we're trying to focus. You know, our philanthropy is in having money for these pilot studies that can allow young investigators, because sometimes you just need, you know, $5,000 to get things off the ground. The study that I published in JAMA, that was done with $10,000 from the Ovarian Cancer Research Foundation. So it wasn't a lot of money. But, you know, again, you know, we got a lot of people to donate statistical time and whatnot, but I think that's where having those kind of funds, I think, are critical. And I think there are a lot of donors who are interested in being able to provide pilot funding. I think that's I find it an easy sell. And we've done a number of, you know, we work with our development officer. We do a lot of like lunch and learns, and we identify, you know, patients who have capacity, and you know, we invite them to, you know, a session where, you know, we might have a couple of physicians sort of talking about some of their passions and whatnot, and the research and some of the discoveries that we've made. And, you know, we almost always get enough for at least a couple of pilot projects for junior faculty when we do these things. So I view these as really worthwhile in my time to do this. So I'm spending a lot more time now doing philanthropy than I used to. And as I said, I love having funds that are unrestricted, that we can kind of do whatever we want with. But I think that more and more, we as physicians or as researchers, we have to really take this whole philanthropy piece super seriously. I think it's going to be vital for our existence, you know, going forward. And that, to some extent, we all should have some training in philanthropy. So, when somebody says, thank you so much for the great care, you have to be willing to say, if you'd like to, join me or learn more about the work that I do, we'd be more than happy to do this. But it's a whole change in mindset and how we talk and what we do. So I do have plans for, to have some sessions with the faculty just to get people comfortable with, it's not a bad thing to ask people if they want to join you in your, in what you're trying to accomplish. And we have to look at it as providing people an opportunity rather than asking for them for money. I mean, that's really what how I think we have to how we have to think about this. But it's an uncomfortable place to be. So.
Another person for us to take advantage of her abilities is Rachel Weiner. I don't know how many of you know her or have worked with her, but she's the one who did the study that involved in any case, she, as women entered as freshmen, she had began a program of self-testing. She showed that when you graduate from the UW, you not only get a degree, but
You get HPV.
72%
Yeah. Yeah.
There was almost nothing being done about it, but lots of interest. And I think engaging somebody who's an epidemiologist together with the clinicians that you are for doing this program quite helpful. I think she could use you guys as well.
Yeah.
That was a wonderful talk, and you, I really appreciated your list of 4 global health priorities at the end that you thought might be starting points for more collaboration. We've chatted a little bit about the whole area of family planning contraceptive services and what the gaps are and where the areas of potential existing interest align with the needs out there. Do you want to say a little bit more about any of those starting points in your view? And that might be an interesting thing for us to just talk about briefly here, because I personally think that's a no-brainer for us to be holding hands on, as we've talked about. And there's a little bit of urgency in trying to move that forward. So I'd love to hear more about people's ideas.
Well, not being a family planning person, I feel a little bit unprepared to sort of talk about family planning and the best message of research, and so I just have to say, I would have a hard time sort of thinking about. I mean, where do we start with that, and not really knowing the global landscape as well as you all do. I think it would be difficult for me to really comment on that. But as we meet and we develop that, and we get some of the content experts in, I think we can sort of flesh out, what makes sense to do. But maybe I'll turn it over to Jenny. Do you have comments about? And Liz, yeah.
So, I mean, I think when we talked about the strategic hire between the departments, if that's at all possible to have some leadership, I think for a more senior person, and I've talked to Allison Drake actually since when we were in Kenya a lot about what that phenotype looks like, and he sort of gave me that advice of like, find that person, start talking to them, go out and look for those people, because they're not going to come to you. You have to really, and that was really great advice. So we've been strategizing around, like who is the person we're imagining that would be a really huge benefit to two divisions. And then I think about Elizabeth's thoughts on this too. I mean, as we've been doing this SWOT analysis that Judy got us all together to really think about, because I think we don't always know what's out there and who's doing what and where the real need is and where our need should be. I think it remains in health services and implementation science as strengths of both departments. I think for health services, our family planning division
Mhm.
like proteins together, so we just need the solidifying.
Yeah, I guess I haven't been part of those higher level kind of conversations about strategy, but I'm excited that they're happening. And I guess from my perspective as kind of a much more junior person, I see a lot of possibility for collaboration with the adolescent kind of age group, and with all the lessons learned from HIV prevention and all the work that's been done there, being able to have kind of junior level people piggyback off of all the exciting things that are happening with pre-exposure prophylaxis and all the grant funding that's happening there, seeing how we can work family planning into that a little bit more. I think that would be a really amazing opportunity for people who kind of want to work with these really established researchers
Mhm.
like
Mhm.
but also want to bring family planning more to the fore.
Mhm.
And so I see a lot of opportunity there. And
Yeah, I think anytime you can piggyback on to something else that somebody's doing, you know, particularly if they've already laid the groundwork, that makes a lot of sense to, you know, to be doing that.
and with all the enthusiasm of kind of the Gates Foundation with adolescent sexual and reproductive health, I just think there's a lot of promise there.
So, family planning cuts through all, from the teenager on up to the older person, but, you know, to your point of going back and asking the women, one of the most powerful things I've seen in the last couple of years was Bill Brenner and I attending one of your sessions where 4 women from Africa came in and said, look, we want family planning to keep from dying. And so when you get maternal death rates at 1,000 per 100,000, and you have 6 pregnancies, you now have a 1 in 15%, 15% chance of dying. So they were picking out in their communities the fact that they didn't have contraception, and their friends were dying, and their relatives were dying. So this is kind of an extreme. It probably doesn't exist in East Africa, but it does exist in lots of Africa. And I think one of the things we go back and ask the women themselves what they want. I think that's another thing that we would want John to do very much like we did with Ovarian.
Mhm. Cool.
We are at time, so I think we'll stop the formal portion of the talk here, and I just want to thank you again, Dr. Goff.
Oh, thank you for having me. Yeah,
Hopefully we can mingle a little bit afterwards.
sounds good. Thank you.